Tonight is going to be part one of two parts. I'd like to say this is recession-proof dentistry. I think recession-proof dentistry for the general dentist, which we're going to get into, is really all about hygiene. I have 4 amazing hygienists in my practice. I'm tough on them. It's tough love. But I would absolutely say as a core group, this is what grows your practice. And tonight is part one. It gets into the financial side, how to be a little unique in your thought process, and far more. Part two of this series will really get into cone beam, Perio Protect, implants, so much advanced stuff that most people don't even think about. Why would a tray be that special with cone beam and all these things? But I'm telling you, it all ties together, and that'll be in September. As I move forward, the key question is, how are you changing for success in your future? We meet every 2 weeks in my office. We spend 2 hours every 2 weeks on a Tuesday afternoon, and everything is detailed, everything is planned. And it's amazing what it takes to guide your office. And the question is, why would you guide your office? Taking 2 hours every 2 weeks, and I'm going to tell you these are changing times. And when I say these are changing times, these are unbelievably challenging times. And you're going to see throughout this 1 hour. So from dentistry today, this is a startling graph. In 2005, the average dental salary peaked at $220,000. I teach 40 courses a year around the country. And to say dentistry is booming is a joke. It is not booming. You're going to see why in the next 10 slides. It is not booming. And tonight's all about how can you take back your practice? How can you grow your practice or even raise your bar in your practice? And it will talk about you making more money, your team making more money. And it's not about money. But if you're working your butt off, in my eyes, why shouldn't you benefit with a growing income versus a shrinking income? 2 out of 5 dentists in the ADA poll in 2013 said they were not busy enough. And that is absolutely correct, if not an understatement, that 2 out of 5 dentists say they're not busy enough. And because they're not busy enough, the Delta Dentals get to grow. And what Delta Dentals really do is they want you to be obviously in their network and not an out-of-network dentist. In California, as an example, after you have treatment done, Delta Dental will send an email out to your patients and say, "Dear Mr. Jones, your fee today was $999 for a crown from Dr. Graham. Their normal fee is $1,499. Thanks for being a Delta Dental client." And unless you start to understand that PPOs are the death of a practice in many ways, and not the growth of a practice in many ways, that's what tonight's course is all about. What percent of U.S. dentists take PPOs? In fact, 7 to 8 PPOs in their practice. It's a startling number. 68%. 68% take 7 to 8 PPOs in their practice. That means you're working harder for less reimbursements. So is there a way around that? I'm going to show you tonight. If you're busy, you would never be taking 40% less on the dollar. 40% less when your overhead is 60%. It's just the way it is. The ADA study showed that PPOs are just going to continue to grow. They're going to dominate dentistry, and they're going to be a continual factor in how we proceed. So thinking in the box, it's 2005. I look up in the sky. I'm going to the U.S. Tennis Open. I look up in the sky, and there is the MetLife building. And MetLife was an instant buzzkill because I look at MetLife as the box. MetLife is the #1 insurance provider at the University of Chicago. And I'm going to tell you, I do not take MetLife in my practice for me personally. And I'll have one junior associate who does to grow them. And once they grow their practice, then we'll bring in another junior and let my other associate continue to grow their practice. Why? MetLife thinks in the box. And when you look at it, MetLife thinks only one way. MetLife thinks no. I haven't done anything in this picture. I looked up in the sky. I see one way. I see a red light, and I see MetLife. So what this tells me is that MetLife is not the answer, nor is Delta Dental. So how do you think out of the box? In dentistry today, you have three options. The dying solo practice, which is shrinking tremendously. The group practice, which I'm happy to be a part of. And when I say group practice, I'll have 2 or 3 wonderful associates, specialists in my practice, 4 great hygienists, 4 great assistants, and 3 great front team members. I'm not a part of a dental service organization. And the truth is, the largest 2 growing groups are group practices and the dental service organization. So what's your future? Is this your future? So this works. This is Walton's 5 and 10 store before Walmart. And is Walmart what you want? Do you want to be doing composites for $60 or $80? Do you want to do Profis for $48 and have it PPO driven? We had a consultant come in 2 years ago and say, hey, Profis should be every 30 minutes. That would kill my Tania, my Gwen, my Celia, and my Allie. I just don't want to do that. That's not my vision. Now, mind you, obviously Walmart's done amazing, but this was their beginning. It's just not my vision. So what's my vision? I'll take it from the Walmart to RH, which is restoration hardware. Great store, great quality products. So Restoration Hardware has a members program. You buy a card for $100 a year. And for $100 a year, they call it the Gray Card. And as a result, with the Gray Card, you get 25% savings on everything in their store, an additional 20% savings on sale items. You get all these extra benefits because you bought a Gray Card. Why? Because they want your business. And if you spend $100, you're going to come back and give them your business. So the question, why aren't we doing that in dentistry? So 2 years ago, my office, through our Tuesday meetings, decided to launch our University Dental Plan, a UDP dental plan, because my office is called University Dental Professionals. I will share this plan with everybody. All you have to do is email me. My office manager and I will send you all our marketing. It's unbelievable how well this works. So we launched our own plan 3 years ago. And the plan is all based on hygiene and prevention. So we created this University Dental Plan or University Dental Professional Prevention Plan. And I'm just so proud of it. And this is really what's involved. My practice highlights age health-related dentistry. Age health-related dentistry means I treat patients based on both their age and their health. So if someone's 46 years of age and healthy, how do I preserve their teeth to their 85th or 90th birthday? It's certainly not having a 2-surface composite turn into a crown. I compete against so many over-aggressive dentists. I'm not aggressive because I treat my patients in a conservative tooth-preserving ideology. That's the fundamental nature of how I practice and all my hygienists practice. My entire practice is fundamentally about a periodontal restorative approach. And my hygienists, my periodontists in my practice, it's state-of-the-art periodontal therapies. I'll explain more about my diagnostic tools in my practice, and it's about prevention at every age. And geriatric patients, which is far more my specialty. Older people are just incredible to talk to. But the most important thing is they need prevention. And everything that is on the screen is about hygiene-based growth. It's all about hygiene-based growth. So this is my in-office dental plan. This was year 1 of our brochure. In year 1, we offered the UDP prevention plan. And I won't get heavy into it tonight, but basically, we charged patients $300 a year. They were given 2 free Profis a year, and if they needed Perio maintenance and 4910s, it was all prorated, and they would get 15% off of those treatments. So basically, if you get 2 hygiene appointments, 2 Profis in my practice, that equates to $200. If you need $900 worth of 4910s or some scaling and planings, the $200 comes right off the top of the $900. and then they get 15% off. This includes yearly periodic exams, yearly Perio exams, was bite wings, and 15% off everything in my practice, everything. They just had to pay a time of service. That was the principal part of the plan. For patients who had flex plans, they could pay a certain amount of money, it was $100 for the year, and you'll see where we went from that. Or even patients with insurance. They would give us their insurance and we just give them a 15% discount across the board. Our goal was to convert PPO patients. Our goal was to attract new patients on our website. Our goal was to add value to our current patients and target growth. This equated to huge growth. That is happening in all of our practices. The ADA said we're going to grow with 70-year-olds and above. That's the private enterprise of dentistry going forth. And this plan really targets those patients. They don't have insurance. They love our dental plan. It is not insurance. It's a dental plan. In year 2, we raised our prices across the board. My team was fully trained on Dexis's Carry View, Air Technique Spectra. My hygienist had them all in their operatories. We got our first of 2 cone beams. We would offer all-on-4 treatments, all included now. And we raised our fees. So we could annually raise our fees of the plan and raise our fees in the practice. And it was year 2 of growth. We raised the annual membership to $345 from $300. And across the board increases in fees. We changed our look. We added 2 new doctors. And you can all do this. We did this all ourselves. We didn't hire anybody out. And what you can see in our UDP Platinum Prevention Plan, we include Carry View and Spectra as part of our complimentary diagnostic fees, of course with Velscope, oral cancer screening. So we upped our game, upped our pricing, and our practice has continued to grow and grow and grow. And we are surrounded in a community by dentists, on average in my community, taking 11 PPOs per practice. I know that based on a group we hired to understand what my surroundings were all about. 11 PPOs in the average practice in my community. Why do I love this? It allows patients to have an affordable dental plan without any premiums. Okay, so basically the patient pays $345 a year and it builds our hygiene program. There's no discounts, any special discounts anymore. We have one plan. We use a system called comprehensive finance, but that's a whole different system in general. We get cash in our account up front. And really, it's quite interesting. For us to maintain our patients, we've moved away actually from Solution Reach. And now we use a system called Weave, an amazing new system. And what happens is these systems allow us to run our practices far more efficiently. And we've incorporated their phone system, and there's far more to it. And you'll see it on part 2 of my course. Truly, all these things are how we innovate. We were following our growth on Dental and Tel, and you'll see some of their numbers. And now I'm moving from Dental and Tel to a system called ClariCare because that even can continue to offer more. 2 great systems, though. 2 great systems. But what I really love about all these things is that I don't have to ask insurance companies for anything. My patients get what they want. It's for what's best for the patient. And an example is Perio Protect. And you'll see this tonight. Why should an insurance company determine what I want for my patient? So I'd rather just give it to my patients and let them get a 15% discount across the board. What would I have done differently? And this is important. The first thing I would do, I'd do an audit on customary fees in your zip code. Get your fees to a level before you start discounting 15%. I would have raised my fees a little bit higher to offset the discount. I am now thinking about offering a 13% credit card discount and a 15% cash or check discount, because credit card companies routinely take about 2% off the table. We have a great credit card processing service. Email me and I'll save you a fortune of money. It's my pleasure. They saved us on average $400 a month, close to $5,000 a year. We reviewed it through the Catapult group, and of the 11 reviewers, all 11 saved from $190 a month to $800 a month. This is business. And you don't have to offer 15% or 13%, but that was the discount we felt. And the last thing I would do is I would not just do a blitz to all your patients. Start with the A's and the B's, and 2 days later go to the C's and the D's, because the phones are going to ring. People will want to know about the discount, so who's going to answer these questions? It's a whole systematic way of doing this. If you email me, I'll be happy to tell you more. But you don't want to send out 2,000 emails and get 250 calls. That's what we did, and it was a huge mistake the first morning because we couldn't answer all the calls. So you better have your language together. You better have your answers together, have your marketing together. But I'm telling you, your patients are going to love this, and you're going to see less PPOs in your life. So then the question is if you're doing less PPO work and you're doing more and more growth, how do we build hygiene into a recession-proof practice? And building success in hygiene is all about the reappointment process. The reappointment process is absolutely essential, and it leads right into what I would tell you with these business analytic systems today. The first rule in business management is you got to know your numbers, and most dentists have no clue. They just know what they produced last month, what their checking account has, what they collected. That's all. That's most dentists, and that's certainly not enough. So one key indicator number that really shows value is demonstrated by the patient to the hygienist is the reappointment percentage. If the patient doesn't see the value with the hygienist, they're going to have lower reappointment numbers. They're just going to have lower reappointment numbers. So let's go back to that. There's my Tania asking a patient, when can I schedule you for your next 3-month, 4-month, or 6-month appointment? And if the patient says, I don't know, I'll let you know. That patient, if they don't make that reappointment process, now you've got to send them recall cards and blah, 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 and waste all your time. But on the other hand, if they appreciate Tania, and my patients do, they'll make that reappointment. If they don't, within all these systems today, they say, can you call me back in 2 weeks? We enter it right into our system, and we'll call them exactly in 2 weeks and reappoint them then. And we're going to talk about this reappointment process. It is essential to the growth of your practice. So how do you check if you're growing? How often do you check? How do you follow trends in your practice? How do these trends direct you in your practice? Let me just say this. If the hygienists are reappointing their patients at the level I'm going to show you mine do, then my front team now has so much more time to grow the office because they're not calling patients, sending out a gazillion cards, please come in for your cleaning. This is the 11th card we're sending you. The reappointment process is essential. So how do my hygienists create this value? In today's modern day practice with the modern day hygienist, my hygienist performs so many amazing, what I would say essential features that go into the growth of their practice. Sounds simple, but they must create warmth and trust and respect, and most hygienists are wonderful at this. If all a patient does is come in for a cleaning and a goodbye, good luck to you retaining that patient. That is a PPO-driven practice. Warmth and trust are absolutely essential. But beyond the warmth and the trust, my whole practice revolves around the 60-minute appointment called the wheel. So as we get into our educational course right now, let's talk about the wheel. The wheel is a 50-minute or 60-minute appointment for people who have their teeth. You don't need an hour if someone walks in with 3 teeth, but we call this the wheel. The wheel is broken down into segments of that 1 hour. It starts with the hygienist conversing with the patient, which is building the relationship. The hygienist saying, I took an online course with Dr. Lou Graham. I went and took a course about lasers, establishing credibility. Then they're going to go into their clinical screenings, which takes a bulk of their initial time. Then they're going to share the findings with the patients. Then the doctor's exam. Then they got to do oral hygiene instructions. Normal instrumentation is no more than 20 minutes in a 0110 or a 4910. If they need more than 20 to 25 minutes, they should be in active therapy. That's it. I'll say it again. If they need more than 20 to 25 minutes, they should be in active therapy. And that's the wheel. So it's all about all of this. Building relationships, credibility, and creating value. That's what my hygienists, and I'll show you their results. Understanding what really goes on in that hour is the 3 C's of prevention. What are my hygienists checking? How do we control, aka in prevention, and how do we contain problems? And this becomes essential as the 3 C's of prevention. And this is my mantra in my practice. So in 1 hour, my hygienists have to look at the periodontal status, the restorative status, the patient's oral health, oral cancer, occlusal health, and then they have to share their findings with the patient all in 1 hour. Sounds so simple, and it's so not. With occlusion, my hygienists have to look at mobility of teeth, wear, fremitus, and function. For example, I'll walk in and Celia will say to me, when the patient bites down, the patient has fremitus on tooth number 10. I would have missed it. Or Tania will say, when I'm examining this patient, I'm noticing more wear. iTero's coming out with a cool program about you scan a patient and you can monitor wear. This is where we're all going. I want my hygienist to tell me all these things because it's all about controlling and containing potential problems. They do oral cancer screenings in a 1-2-3 approach. It's a visual, it's a manual, and then we use Velsco. We practice sequential therapy. It's our approach to active therapy, where we go after the deeper pockets always first. And then we follow up and treat them a second or a third time, all with lasers. Every one of my hygienists has to be laser certified or they cannot work in my practice. They each have their own diode laser. I hear it beeping all day long in each of their operatories. We do DNA testing when we feel we're dealing with refractory problems or problems we're not controlling. Another adjunct in our practice, along with, of course, localized antibiotics that can be working with lasers and other therapies. We use Carey's Diagnostics in the hygiene chair. They use Spectra and CaryView because Spectra is far more diagnostic than an Explorer, and CaryView is far more diagnostic than a bite wing X-ray looking for traditional interproximal decay. My hygienists all have to wear loops and lights, otherwise they can't practice with me. If I need a loop and light to see things, how do they not? So this is mandatory in my practice. They have to understand intraoral camera use. How do we show our patients? We all can get lazy, but this is how you grow a practice. We use Guru for communication. Why do you need this work done? Here are some animations. And this all leads into communication. My hygienists understand sometimes why we need a 3D CBCT scan to help diagnose issues that you cannot see in a 2D. This will be in September 6th. Now, this is all stuff that hygienists routinely just don't do. Hygienists routinely cleaning teeth and just doing oral hygiene instructions The bar is raised in my practice because the more my hygienists diagnose, the busier everybody is in my practice. And this is how you grow a practice. And we specialize our practice in creating customized hygiene protocols. It's far more than just a power brush and floss or a bass technique. How do you customize protocols? And one of those in our practice is Perio Protect. This is absolutely a home run for our refractory patients, but it's so much more than that. I'm going to get so much more into Perio Protect in September. You'll see it's just such an advanced technology of what we can do in our practices. So you do all that in your practice, and it leads to the most important thing, the continuity of care. And that's the reappointment. If they don't show up in 3, 4, or 6 months, how are you continuing the care? So you have to build that value to create that continuity of care. And this all folds into hygiene-based growth, and it's all about building that value. So the wheel, 20 minutes for instrumentation, 20 minutes for a 4910 or a 0110, 25 minutes. Patient comes back after 3 years, and they've got bleeding everywhere, 4s, 5s, 6s, and 7s, and you do a 4910 or a prophy, you're giving away your work and you're not treating them adequately. You're not. So the wheel really is far more involved in clinical screenings, sharing the findings, and I'll show you what that is. So the first is, and I got to do we're right now reviewing a new loop company called Q-Optics. They're not new, but Susan and I, my partner in crime, we got our Qs. And I got to tell you, as far as loops go, second to none. My hygienist Gwen has it. They're just amazing loops. They're thin, great lenses. And how can your team not be using loops and lights? There's Gwen with hers. But this is all what's involved. So this is what my hygienists do for clinical screenings. They all have to know Velscope. They all have to know Carry View. They all have to know Spectra. Of course they need digital x-rays, and then they need an intraoral camera. And here's what I'll say about my intraoral camera. Later this year, we'll be releasing a camera called Smart Mirror. It'll be illuminated on both sides with the most incredible LED lighting, video camera right in the mirror so your patient can see what you're doing or what you're diagnosing right there on the screen. The handle will be voice activated for the hygienist to do perio charting right into it. And this is just step one. The mirror will probably become the most amazing instrument in dentistry for communication, a mirror. I love how this practice is called Smart Mirror, and we'll be launching it later this year through Catapult Education. So why do you need all of this stuff to communicate with your patients? And the truth is, every company will tell you, you have to make patients want and need their treatment. And how do you make patients want and need their treatment? It's not about telling them. It starts with showing them. And it's far more about sitting a patient up and involving them. This is what my team does. This is my hygienist, Gwen, involving a patient, explaining, sitting upright, what's going on. And that's the value of communication. And that's where we're all going further. Creating this want and the need. Here's Spectra. And my hygienists all understand how to monitor occlusal fissure decay or smooth surface decay. If I can take a reading at 1.8 and say we're going to watch it because it's only an enamel and 12 months later it's 2.2 into dentin, and an Explorer is not sticking because an Explorer is just 50% accurate at best, my hygienist, I can walk in a room and they'll go, here's carious changes on number 30 or number 3. And the same goes with Carry View. You use transilluminated light and you can see interproximal decay that you cannot see on x-rays. And this only makes you all busier, but this all goes on in the clinical screenings with my hygienists. I'll walk into a room and a patient will have a cracked tooth. There's a Carey view image. My hygienist will have a tooth sleuth out. She's already shown him a guru video about what a cracked tooth is, and this is how we grow our treatment plan acceptance. It's all about the team. That's what I'm trying to share with you in our hour tonight. And then you use guru animations or whatever animations you want, and this is a Perio Protect animation about what Perio Protect does. And how do we use Perio Protect? Well, if a patient's going to spend $450 on a tray in my practice, and I want to show them what brushing doesn't do, we're going to show them what the peroxide gel does. Of course, you're going to want an animation to show them what they're doing. And this is what my hygienists do to explain to patients what they need. And whether it's a cracked tooth, whether it's a home hygiene instruction, it's just amazing what we can do. And then you need intraoral cameras to take pictures and show patients why they're getting so much decay and why plaque is the #1 culprit. And this is also essential. All of these are essential. So what is each provider's treatment plan acceptance rate? Do you know? What's your acceptance rate? What's the acceptance rate percentage-wise in your practice? Would you want to know that information? This is where data analytics all come. I can see, for example, how many cases are presented and how many are accepted. I can follow this per doctor or per hygienist. So if I have 5 associates and one has a low percentage for new patients, why do I want to put new patients on his or her schedule until I train them how to do exams the right way? Here's an important question because it's on the quiz after the course. What % of treatment plan casework is begun in the first year in dental offices? It's an amazing number. Only 22% of all diagnosed treatment plan work is started in the first year in dental offices throughout the United States. It's terrible. So people are not seeing, they're not desiring, they don't get the need, they don't understand why they need this dentistry, and then they don't want it. So in my practice, we can follow even, this is my patients, 61,000 presented, 47 accepted, and you can see on the bottom of the screen, okay, where if patients come in and they have unscheduled work, that's who we're going to go after and call. So my acceptance rate here that month was 78%. Here's our overall practice of $133,000 presented, 75 accepted, and you look at the unscheduled column, I've blocked out the patient's names. Anybody who doesn't have a scheduled appointment, we're calling. This is how data analytics grow your practice. They're huge. So for $3,000, $4,000, $5,000, you're going to grow your practice $100 grand. How can you not spend this kind of money for data analytics and have your front team geared who to focus on? So does the wheel work? Are these technologies worth the investment? Does this increase in ROI and your value in your practice? So here's what I can show you. June of 2016, my practice was doing $150 per hour in hygiene production. In 2016, October, 1 year later, less than a year later, we were up to $160. We can see what we're not doing, what we should be doing, and this doesn't even include x-rays. In 2014, we were at $137 in June, and you can see how these numbers grow. They're huge numbers. You can see which hygienists are not doing fluoride treatments or which are not doing scaling and planings the right amount that they should be. Why would one hygienist be doing 26% active therapy in your practice and another hygienist doing none? This is how these data analytics all help. The average hygienist in the United States produces $112 per visit, not including x-rays. Imagine growing that to $160. This is recession-proof dentistry. So on the reappointment side, How do I know we're growing? My hygienist in October of 2016, when I looked, had 289 visits and 271 of them reappointed. 15 were unscheduled. Many of those we had follow-up calls planned. Now my front team isn't spending their time sending out recall cards. And my hygienists, they're killing it by reappointing their patients. This graph just shows some hygienists showing 98% reappointment that month, another showing 96, and another showing 89. And let me tell you, they all care. They all want to be reappointing their patients. They all get it. It keeps them busy and it gets them right to their bonuses. So just examples of creating value. Customizing your hygiene. This is why we take pictures of patients. They don't understand why they're getting cavities. Really? And they tell me they brush their teeth 16 times a day. Really? So here's a power brush. We're a huge Oral-B office, and we love our test drives. And our test drives allow us, and if you're an Oral-B user, these are all the things you should be doing. We have our patients come in, and we watch them brush their teeth. And why do we do that? Because we want to see why they're not getting all their plaque out of their mouth. Or when you're delivering a system, we go through this at length with our patients. But all of this is how you build a practice, not how fast in and out, not by seeing 18 patients a day. And the power of a power brush, are you kidding me? In a geriatric practice, and the bristles, how they're customized with these rounded heads, huge. Look at how it gets in between. You're not going to get this with a manual. You're not going to get this with power brush traditional head. Almost an interproximal head. This is the power of power brushing. So these are all part of the ways we spend the time building value in our patients. And now I'll shift direction. And I'm going to talk about, to me, one of the biggest things over the last 2-3 years of my practice was how we started treating refractory perio. Last year, in June of 2016, I presented Perio Protect to my team. This is our calendar of what we do on Tuesdays in our practices. We try to have a calendar. This year we've been slacking. Got to yell at my team on our calendar of what we should be doing. But this is really thinking in the box. This is a perfect example of how really this doesn't work for our patients. So there you are, and you got that look. I just keep cleaning their teeth, and they keep coming back with bleeding pockets, and they're just not getting better. And the question is, you got great hygienists. They're doing their typical ultrasonic scaling, some hand scaling, and the patients just don't get better. Well, why? And this was a study done about toothbrushing, flossing, scaling and planing, chlorhexidine, localized antibiotics. And what this study did was it was printed in obviously the Journal of Perio, and it evaluated the gold standard. The gold standard. What's the biofilm management of AA, PG, and BF? These are the 3 bad bugs of the 8 bad bugs in the mouth. And what did the study show with pocket reduction therapies, surgeries, Whitman flaps, chlorhexidine? What did the studies all show? The studies all showed that regardless of the treatment that you did, the prevalence of the target species was back 1 year later. So it's back. So these results suggest that the prevalence of pathogens negatively affect the 1-year outcome of perio surgery and non-surgical therapy. So if they're coming back, how do you prevent them from coming back? And this study was unbelievable by Palmer. If you remove 50% of the biofilm at a hygiene visit, it will regrow back in 3 hours 400%. If you remove 75% of the biofilm, it'll regrow back 300% in the next 3 hours. So imagine you've removed it and it's already growing back. That's the problem. So you have patients who they come in, they get their hygiene visit, and what happens over the next 3 months? How do you maintain those patients from breaking down? That's all I'm asking you. How do you maintain them from breaking down? They're on a power burst business. Many of your patients can absolutely maintain themselves, and many of your patients just can't. They show up 2 months late for their 3-month recall and they're breaking down because they've missed their 3-month visit. And so the key part of this is maintaining those patients throughout those 3, 4, or 6 months. So thinking outside of the box or outside of the, the way you're thinking, or really thinking outside of the pocket, how do we make things better? So tonight, in the last 5 to 10 minutes, I'm going to show you an entirely new approach to perio maintenance and long-term health. There's no investment in this. It's the easiest learning curve. Your entire team is involved. Your hygienist, your assistant, and you. And your patients are the winners. They get better care. And it's really the world of Perio Protect. It fits right into my wheel. It fits right into my mission in my office, and it should fit into all of yours. The world of Perio Protect allows me to customize my periodontal maintenance patients and also my caries management of my high-risk patients with their tray system. So what's involved? Your assistants take quality impressions, which I'll show you in the next 10 minutes. The hygienist provides a full mouth perio charting, and the hygienist and the doctor provide a periodontal diagnosis. That is sent on a form to one of 5 labs that are FDA cleared to make Perio Protect trays. The way I take impressions, or my assistants do, we don't take alginates because that means we have to pour them up, and I don't want to pour them up in my office. So routinely we were taking the alginate alternative. Kettenbach, wonderful direct manufacturer, makes a product called Silginate. And in order for you to take a good impression, you have to capture not just the teeth, but the tissue cuffs all the way around. That's one way of doing it. And our favorite now is using Kettenbach's Panasil Putty wash, putty and wash. So routinely what my assistant will do, she'll put some wax molding just around a non-custom tray, just a typical plastic tray. She'll take a scoop of the Panasil putty, obviously the catalyst and the base. You can use gloves. She'll mix them up and make like a donut. And before she places it in the mouth, all she does is take the Panasil light body. And she injects the light body over the putty. It's then inserted into the mouth, and 2 minutes or 2.5 minutes later, whatever the working time is, this is the kind of detail she gets from a putty wash system. This is routinely what we're sending out. Is 2 to 3 weeks later, we're delivering the trays. So the impressions go out with a diagnosis and probings. My assistants were trained online. My assistants are delivering the trays. I'm, of course, coming in and checking. How simple is this system? Seriously. Patients who want to feel better are willing to do 10 or 15 minutes a day. They place peroxide. I'll show you the peroxide. It's a special peroxide. They place it in the tray, and they wear these trays 10 to 15 minutes a day. That's it. 10 to 15 minutes a day. 2 to 3 times a day when they're in treatment, because when they're in treatment, it's something. If they're on maintenance and you've done everything and now they're in maintenance, my patients wear them 10 or 15 minutes. If it's pre-treatment, if it's during treatment, my patients may wear them 10 minutes in the morning and 10 at night, 10 in the morning, 10 at lunch, and 10 at night. But routinely in maintenance, it's 10 or 15 minutes. And where do they wear them? They wear them in the shower. I love this tip. Your patients routinely take showers every day. So we tell the patient, load them up, wear them while you're taking a shower, take them out 10 or 15 minutes later and brush your teeth. How do they clean these? They just rinse them out in the shower. It's that simple. My patients love the freshness. Their teeth get white and they love the freshness. So they're self-motivated. Their gums feel better. They've been dealing with perio issues, some of them their whole life. Who's not going to want to feel better? Who in their right mind wouldn't want to wear these 10 or 15 minutes a day? So then I go back to you. And And literally, I end our night talking about these things. How do you treat patients whose periodontal issues never get better? You have at least 10% of all your patients, if you're seeing adult patients, have refractory periodontal disease. Or patients who don't want surgery. Or patients who are just not getting better with 4910s every 3 months. How do you take care of these patients? How do you manage patients in a better way to minimize bacteremias, especially in your medically compromised patients? Imagine if patients were wearing these trays coming into your office and now they're bleeding less. That means less bacteremias, less potential issues. We do pre and post rinses with activated chlorine dioxide with a system called OraCare before we do hygiene therapy on our medically compromised or our aging patients. We want to minimize bacteremias. How do we manage patients who have implants and we want to prevent periodontal issues around implants? I just was at a course, and the course stated up to 47 to 49% of your patients who have implants will have periimplantitis or inflammation around those implants. That's what we're talking about. So in September, what I'm going to get into more, far more, on Perio Protect is about how this is used before, during, and after your care. And the concept is all about the ability of peroxides to debride subgingival planktonic floating cells within the pocket and reduce the peripheral elements of the biofilms within the pocket. That's the whole concept of what you're trying to do. These peroxides shift the biofilm communities into a defensive mode so there's less growth and less reproduction. It's an FDA cleared device. It's not a suck down in your office. These labs go through a specific way of creating a customized approach. So let me just close with two things. The Perio tray differs from all other trays and mouth guards. So many people think they can just make a mouth guard, and they can't. But what happens is when you send the Perio probings in, the labs make these specialized seals, and these specialized seals create a gasket, and the gasket becomes the key. And here's our last slide. The key is overcoming the crevicular flow. So when you wear a Perio Protect tray, what happens is the hydrogen peroxide of the 1.7% gel keeps the gel in there, oxygenating the pocket, which then creates a shift in the planktonic bacteria and a shift in the biofilm. That's the key. When I get back to you in September, I'm going to walk you through 4 to 5 cases, and then I'm going to show you advanced approaches. It'll be 100% advanced approaches. So I just want you to understand that's why there's a part 2 in this. And I think the critical part is you need to get 3, 4, or 5 cases going in your office prior to you coming back in September 6th. Because if you get these cases going and start seeing the results, all of a sudden your ideas are going to go, wow, how much more can we use this in our practice? I'll show you pre-treatment cases, during treatment cases, maintenance cases, refractory cases, implant cases, geriatric cases, and that's what we'll do in September. I'll handle a few questions and then I'll let you all get back to your Wednesday night. I just want to say thanks so much for your time tonight. So first question was, when the patient has your dental plan and also insurance, do you bill the insurance company the full fee for the crown or the discounted fee? We bill the insurance company the discounted fee. So what will happen is in our practice, a patient will pay $150 if they have dental insurance. And if they have $1,000 coverage and $1,000 doesn't cover anything, they'll pay $150 a year to be on our plan. And that's how we do it. So the insurance company is billed a 15% discounted fee. Now, our stipulation for everybody out there is the patient has to pay a time of service and the insurance company pays the patient. So we only send the bill to the insurance company of the discounted fee, far less than a PPO fee. And the insurance company must pay the patient. That's the stipulation when you're in our dental plan and we use our dental insurance. Okay. What do you normally charge for trays? So fees, which I'll get into next visit. When we launched our Perio Protect fees, they were $275 in arch. Our cost was $100 with the impression itself. So we were making $175. What I can tell you is our results were so amazing that we started raising our fees to $300, $350, and $400, and now our fees are $450 in arch, and we include the gel for a year. So they can get a 15% discount on that, but what you have to understand is, so it's $450 per arch, including gel in my practice right now. Some people are charging more, some are charging less. But honestly, to everybody out there, where I really make my money in additional to Perio Protect is they're coming in for recall, and we're maintaining these patients and they're growing my hygiene practice. So it's a twofold growth process. But right now we're $450 a tray, including I think 8 tubes to 9 tubes a year. So the question then goes, what about just using 10% carbide peroxide in a bleaching tray? The bleaching tray is made to overlap the tissue, less expensive than Perio Protect. And Ken, that's a typical way of people looking at it. Bleaching efficacy on Perio Protect trays, they are made so well over traditional bleaching trays that cover tissue. They're scored inside, there's this internal gasket seal, and I absolutely believe I get a much better therapeutic effect using their trays than a traditional bleaching tray. B, I use a 1.7% Perio gel. There are certain agents in their Perio gel which minimize free radicals. Long-term use of anything over 3% hydrogen peroxide has not been really clinically tested to be whether there's a problem with it, but Marshall in 1995 showed that 3% or less of hydrogen peroxide, there were no negative changes to tissue. So I follow this protocol. I can understand why you want to save money, but for the $100 that I pay per tray with my bleaching, with my impression, I really honestly, I have no issue at all paying the $100, seeing the therapeutic effects. B, these trays are unbelievably durable. We haven't seen them discolor in 3 years. They're easily cleanable. So it's also the material itself that is FDA proven. So I think they're more than a bleaching tray, but Ken, I really do respect the question. Okay. Average cost of the trays is $86 to $90. I add $10 or $15 per impression, Dilip. So I just rounded out to $100. What is the commercial name of the 1.7% peroxide gel we're using? I order it from Dakota Pharmacy. My email address, Lou, L-O-U, at catapulteducation.com. So it's one word, catapulteducation.com, and I'll get anything you want to you. Next question, what's the Periodontal Protect width of the laminate of the tray? I don't know the width. I would say it's a thicker tray. We've actually used it for soft night guards for grinders. It doesn't really distort. It's incredibly comfortable. You'd have to ask the company what the actual width is, Delmy. I just don't know. Next question. I love these questions, gang. This is why I love doing these. When the patient has your plan and also insurance, do you bill the insurance the full fee? And the answer is yes. How often do we need to remake the trays? That's a great question. So in my 3 years of using the trays, when you take the training, I will tell you I rarely remake trays unless I start trays and then I'm doing restorative therapy. When you do a crown, you don't change the trays. But for example, today I had a patient on the trays for a year and a half and we just delivered 2 new implants and we placed the implants and we gave her number 3 and number 14, we're making a whole new Perio tray for her. I only charge the patient $100 on my remakes because that's my cost. So once they've paid their initial money, they're my patients, I only charge $100 to make a new tray. I would say I make on average 10 to 20 new trays a year based on my restorative changes in my plan. Once you start adding teeth, and you're just going to need new trays, and that's how it works. But in 3 years, honestly, these trays are really, really durable. My next course, I'm going to get into far more advanced ways of using Perio Protect. I use it with a bibramycin gel or a doxycycline gel, and I'll show you that. It's like a syrup, and we mix the two together. There'll be a lot more things we'll be talking about and what you can do with this. When Josh asked me, my buddy in Israel, is it applicable for ortho patients? I will say this to you, Josh. The hardest part is taking the impression and getting a great impression over orthodontic wires. Invisalign and buttons and attachments, no problem. Over wires, we use a lot of wax, but the wax has to be really tailored to be thin because the tray has to fit over the wire. So orthodontically, I've been somewhat limited. Question is, how do labs produce the gasket seal? So what happens is you're actually seeing, you send your probings, and what they do is they score the model, probably with a knife, and it's approximate, but they actually score the model around where your pocketing is. So where you have deeper pockets, they score the model more, and that makes that more gasket-like seal. So that's how they do it. They score the models. Okay, so the next question, can we CEREC scan the arches in place? That's a great question too. I've just started using iTero full models. I've done my first 2 cases with them. Harder to score for sure on SLA models, but I would absolutely say if you're a CEREC user and I'm an iTero user, I'm loving this. So I would absolutely tell you, if you want to try it, contact the company and work directly with the lab and send your CEREC models in. Or they can print up the models from your scan and let them score them. I've done 2 cases with iTero and both fit great. That's what I can tell you. I want to thank everybody for attending. We'll talk soon. Bye, everybody.